We're going to talk about the respiratory system. Okay, respiration involves both the respiratory system and then the circulatory system for transport of gases. Pulmonary ventilation, also known as breathing, is just movement of air in and out of the lungs. External respiration is exchange of oxygen and CO2 between the lungs and the blood. Transport of oxygen and CO2 are actually the duties of the circulatory system, as is internal respiration, which is exchange of oxygen and CO2 between systemic blood and the tissues. Here's some parts of the respiratory tract. We have our nasal cavity, nostril, larynx, trachea, oral cavity, and pharynx. And then if you'll note, we have our right lung has 3 lobes. Our left lung has 2 lobes, leaving space for the heart here. And this is your diaphragm. The diaphragm only contracts by going up and down. It contracts. Let me try that again. It contracts by pulling down. When it relaxes for breathing out, it moves back up. Okay, we have a functional anatomy. Our respiratory zone is where you have gas exchange. This is from the respiratory bronchioles, alveolar ducts, down to the alveoli. And the conducting zone is just taking gas to the respiratory structures. Respiratory muscles, diaphragm, and other muscles such as your intercostals that promote ventilation. Now the nose provides an airway for respiration, moistens and warms air, filters and cleans inspired air, and is a resonating chamber for speech. It houses olfactory or smell receptors. Here's some of your function, your anatomy. This is the root and the bridge of the nose, dorsum nasi. These are the ala of the nose, apex of the nose, and we have philtrum right here, and then the nose hole. Nares is one. Nares, Nares, is plural. Nares. Okay, this is showing the underneath structures, bone. Here's your nasal bone. And we have our lateral septal cartilages here. And this is your major septal cartilage right in the middle, and it goes down between and divides the nose into halves. And then we have our alar cartilages, major and minor. And it's divided by a midline nasal septum. And the posterior apertures open into the nasal pharynx. Rufous, ethmoid, and sphenoid. Floors, hard and soft palates. The vestibule is the nasal cavity superior to the nostril. So just once you get up inside the nostril, it's the vestibule. Vibrissae is hairs, and they're there to filter inspired air. Combined with the mucus, the hairs and mucus together capture dust, pollen, gnats, whatever particles happen to get up your nose, and trap them, and then they're dried out, and they can be digitally extracted in a process commonly known as picking boogers. The olfactory mucosa lines the superior nasal cavity and contains smell receptors. The respiratory mucosa, pseudostratified ciliated columnar epithelium. Mucus and serous secretions. Cilia move mucus towards the throat. And then inspired air is warmed by capillaries and veins. And we also have sensory nerve endings that trigger sneezing. Now, the superior and middle and inferior nasal conchae protrude out from the lateral walls, and they increase mucosal area and allow or enhance air turbulence. And during inhalation, the concha and nasal mucosa filter, heat, and moisten air, because if it gets straight into your lungs, it's going to hurt the lungs. During exhalation, they reclaim the heat and moisture. Now, paranasal sinuses are in the frontal, sphenoid, ethmoid, and maxillary bones, and they are there to physically make the skull lighter weight, and also air goes through them, warms and moistens the air. Now, the pharynx is a muscular tube that connects the nasal cavity and mouth superiorly, and then the larynx and esophagus inferiorly. And it goes from the base of the skull to the 6th cervical vertebrae. So here we have our pharynx. The nasopharynx is the part above the uvula right in here. This is your oropharynx, and then here is your laryngopharynx. Nasopharynx, passageway behind the nasal cavity, lined with pseudostratified columnar epithelium. The soft uvula closed during swallowing. Now, the pharyngeal tonsil or adenoids, as well as the auditory tubes, are in the nasopharynx. The oropharynx is also known as your throat. It's lined with stratified squamous epithelium. And this is where your palatine and lingual tonsils are. It passes for food and air and extends down to the larynx. Okay, here you have your esophagus, and then this is your larynx and trachea. It goes on down here. So you can see you have a passageway, and your epiglottis is going to route air in your larynx, and the epiglottis in the larynx routes air and food. Hopefully food stays this direction, and air goes this direction. The larynx attaches to the hyoid bone, continuous with the trachea. It provides an airway, and it's a routes food, and it's also for your voice production. We have cartilages of the larynx. We're going to go straight to pictures. This is the thyroid cartilage, also known as the Adam's apple. This is the cricoid cartilage here. These are your tracheal cartilages. And here's your epiglottis. This is your hyoid bone. And this is your glottis in a closed position and in an open position. And the vocal folds are within this area here. And when one speaks, one sends air across those vocal folds and stretches or relaxes to make different sounds. Okay, and speech is just what I said, released air over the glottis, opening and closing of the glottis. Pitch is determined by length and tension of the cords. So if you pull the cord really high, you get a really high sound. And if you relax them and make them really low, you get a really low sound. Now, loudness, I skipped there, depends on the force of the air, how much air you put across. If you don't put much air across, you just whisper. And if you put a lot, you yell. Okay, the larynx, the vocal folds are both a sphincter to prevent air passage as well as the speaking vocal cords. The trachea is your windpipe, and it has 3 layers: the mucosal layer, ciliated pseudostratified epithelium with goblet cells. Goblet cells make mucus. The ciliated pseudostratified epithelium continuously moves junk, dust, particles, anything that doesn't need to go up. It's to keep that stuff out of the lungs. Submucosa is connective tissue, and it has seromucous glands. Adventitia is where the C-shaped cartilaginous rings are. And as you see, the trachea viewed from a cross-section looks like a horseshoe. So this is the lumen of the trachea. This is a posterior end. This is your esophagus. This is your trachealis muscle here. And when you swallow something too large, it actually has room to push into the tracheal area to allow you to actually get a big chunk of food down. This is a photomicrograph of the tracheal wall. You can see the pseudostratified ciliated columnar epithelium. Here's your little cilia, and they move junk out of the lungs. Submucosa here, and this is hyaline cartilage. Okay, bronchi and subdivisions, the air passages undergo 23 orders of branching, and that branching is called the bronchial tree. Trachea bifurcates, so you have your right and left primary bronchi, and each primary bronchi enters the hilum of one lung. Then you go into secondary and tertiary bronchioles, bronchioles less than 1 millimeter in diameter. Terminal bronchioles are less than 0.5 millimeters in diameter. This is showing a whole lung. It's showing the trachea. You have your trachea, your superior, middle, and inferior right lung lobe. And then on the left side, you have your superior and your inferior lung lobe. And then here is your cardiac notch. It leaves room for your heart. Okay. The respiratory zone, respiratory bronchioles, alveolar ducts, and alveolar sacs. There's about 300 million alveoli that make up the mass of the lung. So when you look at this next picture, this has got to be disproportional because the whole entire lung has 300 million alveoli. So it takes the little bitty thing is an alveoli. So there's only room for, there's like 150 million right here. So the picture is disproportional. We have our terminal bronchiole, respiratory bronchioles, alveolar ducts up in here, alveoli is a little bunch of alveolar sac. The alveoli is individual little thing. And here we have an alveoli, the individual little round thing, and they're connected with pores. Now, looking at this picture, it's easy to explain what happens when you get emphysema. This pore and this pore may rupture and become one. So then since you don't have as much surface area, you have twice as much space. And as you look at this next picture, you can see your capillaries have got to cover each of these little alveoli. This is a good picture because it shows elastic fibers around each of the alveoli that pull the lungs back closed when you relax. This is your coming off your pulmonary artery. This is the arterial side of the capillary, and it's unoxygenated. So as it contact with the alveoli, by simple diffusion, the oxygen goes into the bloodstream. So now we have an oxygenated capillary, and CO2 goes into the alveoli to get rid of them. Now, you never totally get rid of everything in these alveoli. You never get a total exchange of air, but you just keep pouring in fresh and pouring out old, and it works out okay. Okay, the lungs occupy all of the thoracic cavity except for the mediastinal space, and the root is where your vascular and bronchial attachments are. And then the costal or rib surfaces, anterior, lateral, and posterior surfaces. And this is a picture showing cut through the body, and you can just see how much space these lungs actually take up. This is posterior here, anterior here, room for your heart. Okay, the apex is the superior tip. The base is the part that sits on the diaphragm. The hilum is on the mediastinal surface. It's where your blood vessels, bronchi, lymphatics, and nerves come in. And then we have a cardiac notch for the heart. Left lung is smaller than the right because you have to have room for the heart. So it's only 2 lobes. Right lung has 3 lobes. Okay, and this is showing your cardiac notch right here, and your superior and inferior left lung lobe, your right superior lung lobe, middle right lung lobe, and your right inferior lobe. Okay, this is a cast made out of a bronchial tree, and it gives you an idea, if you remove the alveoli, what would be left of your lungs. Pulmonary circulation, pulmonary arteries deliver systemic venous blood, comes from the right ventricle, and then pulmonary veins take oxygenated blood to the left atrium. The pleura is a double layer serosa. Parietal pleura is the thoracic wall and the face of the diaphragm. It's a little serosa lining on here. And then the visceral pleura is actually the external lung lobe. And there is a potential space that's filled with a little bit of fluid and creates surface tension. The only thing that holds the lung to the thoracic wall, it keeps it from collapsing, is that surface tension. Now, the keys of breathing: inspiration, gas flowing into the lungs; expiration, gas leaving the lungs. Atelectasis is a lung collapse. It could be due to a collapsed bronchial or a wound that lets air into the pleural cavity, pneumothorax. Okay, inspiration is a mechanical process that depends on volume changes. As the volume changes, pressure changes. And pressure changes, gas is always going to flow and fill its container, and it's going to go towards an area of lower pressure. So Boyle's law states that the relationship between pressure and volume of gas, that the pressure is very inversely with the volume. So as one increases, this is with an open top container. So you have an open top container here, and this is the air out here. As you increase the size of it, you have lower pressure suddenly because it's gotten bigger, no more air goes in it, so the air rushes in. And then when you close it back down, you squeeze the air out. Okay. Inspiration is an active process. It's inspiratory muscles contract, so your diaphragm's going to go down, your muscles in your thorax are going to increase. Volume increases, the lung volume increases, so the pressure drops and air flows in. Here's a picture showing the diaphragm. All the diaphragm can do is go inferiorly down. And then these intercostal muscles lift the ribs and sternum, and volume of the lungs is increased and air rushes in. Expiration is a passive process unless you decide to yell. The inspiratory muscles relax, and that causes the thoracic volume to decrease, partially because you have so much elasticity within these lungs. And so as the elastic lungs recoil and the volume of the lungs decreases, it's going to increase the pressure, and that pressure is going to force the air out until it's equal to atmospheric pressure. Now, forced expiration is an active process, and it uses abdominal muscles as well as intercostal muscles. So here we have a picture. The diaphragm is relaxing, your intercostals are relaxing, and the elasticity is pulling these lungs down, so the pressure goes up and the air is squished out of the lung for expiration. Let's see, I think I skipped one here. Okay, factors that influence pulmonary ventilation: airway resistance, alveolar surface tension, and lung compliance. Airway resistance, as airway resistance increases, you're going to have a harder time breathing. Constriction or obstruction of the bronchioles is what causes this, and it can kill you. An acute asthma attack is because the bronchioles constrict so that you can't breathe properly. Epinephrine dilates bronchioles and therefore decreases air resistance. Alveolar surface tension tracks liquid molecules are attracted to each other and to surfaces. So this resists force, any kind of force that tends to increase the surface area of the liquid. So it's a resistance to respiration. And that's why we have surfactant. It's a detergent-like lipid inside each alveoli that reduces surface tension and keeps the little alveoli from collapsing. It's not produced in sufficient quantities in preemies, and they'll have infant respiratory distress syndrome. Now, if you know this baby is going to have to be delivered early, a shot of a corticosteroid will often increase the amount of surfactant available in that lung. So it will be. Okay, lung compliance is a measure of the change in lung volume. And the lungs are not able to change as much if you have scar tissue, if you don't have enough surfactant, or if you have a decreased flexibility of the thoracic cage. Respiratory volumes, the tidal volume, which is about 500 mLs for both male and female, is the amount of air inhaled or exhaled with each breath under resting conditions. Inspiratory reserve volume, and you see the males have a much higher volume than the females, the amount of air that could be forcefully inhaled after a normal tidal volume inhalation. Expiratory reserve volume. And again, males have a larger volume. The amount of air that can be forcefully exhaled after normal tidal volume exhalation. And residual volume is what's left. You never get rid of all the air. The amount of air remaining in the lungs after forced exhalation. There's always going to be some dead space that never contributes to gas exchange. Dalton's law states that the total pressure exerted by a mixture of gases is the sum of the pressures exerted by each gas, and the partial pressure of each gas is directly proportional to its percentage in the mixture. Now, if you look at the percentages of nitrogen, oxygen, CO2, and water vapors, you'll see the pressures that they exert. At 760 millimeters of mercury is 1 atmosphere. This is the atmospheric pressure at sea level. Now, this is Henry's law. When a mixture of gases is in contact with a liquid, such as in our bloodstream, each gas dissolves into liquid in proportion to its partial pressure. However, it goes on to say it doesn't work. The amount of gas that dissolves depends on its solubility. CO2 is 20 times more soluble in water than O2, and N2, nitrogen gas, very little dissolves in water. It would take a very large amount of nitrogen and very high pressure to get it to dissolve. This does happen if one goes under the ocean and is under very high pressure, and they'll get dissolved nitrogen in their lungs, and that's why they have to come up very slowly from the water, because as they come up out from under the ocean, the nitrogen starts coming out of solution. If they come up too fast, nitrogen bubbles are released, and it's essentially boiling blood, even though it's not a high temperature, because the nitrogen is boiling off, and it will kill people. Okay, alveoli contain more CO2 and water vapor than atmospheric air, but still it's low enough that we can get diffusion across to the alveolar side from the blood. Now, transport, oxygen carried in the blood, 1.5% dissolved in plasma, 98.5% is going to be bound to hemoglobin. 4 oxygens bind to each hemoglobin, and then we have oxyhemoglobin. Now, oxyhemoglobin is the bright red oxygenated blood. Homeostatic imbalance, hypoxia, inadequate delivery of tissues. It could be from not having enough red blood cells, abnormal red blood cells, blocked circulation. such as you have a heart attack, so you have hypoxia to that specific part of the heart. Some metabolic poisons prevent delivery of oxygen. Pulmonary disease prevents the exchange of oxygen. Carbon monoxide actually binds to the places on the hemoglobin where oxygen is supposed to bind, and it binds much more firmly than oxygen does. So a person with carbon monoxide poisoning will have to go in a hyperbaric chamber if they are to survive. Okay, CO2 transport, 3 different forms. Dissolve plasma, bound to hemoglobin, but to the globin portion, not to the part that carries oxygen. So we have carbanohemoglobin, and then 70% transported as bicarb in the plasma. Now, when you take carbon dioxide and dissolve it in water, you get a reversible reaction, which produces carbonic acid, which then is also a reversible reaction, hydrogen ion and bicarbonate ion. Chemical factors that control the rate and force of respiration. The number one most important thing is the pressure of CO2. If the carbon dioxide levels rise, we call it hypercapnia. CO2 will accumulate in the brain. Now, why it's going to rise, maybe you're breathing too slowly or you're not ventilating properly. CO2 is hydrated, releases carbonic acid, which then releases H plus ions, hydrogen ions, and that is essentially acetic. So we also have acid receptors and chemoreceptors synapse with the respiratory regulatory centers, increasing depth and rate of breathing when one has too much acid or too much CO2. Hyperventilation, breathing too much, causes CO2 levels to decline. We call this hypocapnia. And when one gets too low of a CO2 level, it causes cerebral vasoconstriction, cerebral ischemia, and one faints. So if your kids say, I'm going to breathe over and over and over again until I die, or I'm going to hold my breath until I die, I just wouldn't worry about them. The CO2 levels are going to regulate the breathing. Okay, apnea is a period of breathing cessation, and this generally is sleep apnea, is what we think about. And sleep apnea decreases oxygen and carbon dioxide exchange, and it results in a higher rate of heart attack, stroke, high blood pressure, and death in general. So sleep apnea needs to be treated if one has it. Okay, oxygen does have some control over our rate and depth of respiration, but you have to get really low in oxygen for it to stimulate increased breathing. The oxygen receptors in the aortic and carotid bodies, and if oxygen levels get low enough, they increase ventilation. But generally, CO2 takes over first. Arterial pH can modify respiration, even if CO2 levels are normal. Things that may decrease the pH, CO2 retention, accumulation of lactic acid, ketone acids in patients with diabetes mellitus, or people who are on the keto diet. Respiratory system is attempting to raise the pH by getting rid of hydrogen ions when it gets rid of carbonic acid, which is getting rid of CO2. Okay, but summary, rising CO2 levels, most powerful respiratory stimulant. Oxygen levels are also a factor, but only if you have a really bad, extremely low level of oxygen, and then pH, which somehow seems to be in microscopic letters once it's translated over into this program. But if the pH is too low, it's going to increase the rate of respiration. Okay, during exercise, you're going to increase the ventilation. We call that hyperpnea. Increase maybe 10 to 20 fold. I call it gasping for breath, but if you're in good shape, we just call it breathing harder and faster. This is responding to metabolic needs. And actually, the oxygen, CO2, and pH will remain constant because the reason you're breathing so hard is to keep it constant. Now, at high altitudes, especially over 8,000 feet, one can get acute mountain sickness, headaches, shortness of breath, nausea, dizziness, and in severe cases, cerebral or pulmonary edema and death. Chronic obstructive pulmonary disease, COPD, has chronic bronchitis and emphysema. This is irreversible, and it has the lungs have a problem forcing air out. 80% have a history of smoking, and if you do smoke, do so outside, because smoking inside greatly increases the damage to your lungs, plus you're killing your kids. So smoke outdoors if you must smoke. Dyspnea is labored breathing, coughing, frequent pulmonary infections. Eventually, they're going to get respiratory failure, hypoventilation, respiratory alkalosis, and death eventually. So tobacco smoke or air pollution. Over on this side, you have the alpha-1 antitrypsin deficiency, and you get breakdown of elastin and connective tissue, and take it 2 alveolar walls here, and they might fuse to become one. So you end up with much less surface area for exchange, because we had capillaries all around here, but now we can only get them all around here. And also you get air trapping. And when this happens, you get dyspnea, infections, abnormal ventilation to perfusion ratio. That means you breathe real hard and still don't get oxygen where it goes. Hypoxemia, hypoventilation. On this side, continual bronchial irritation and inflammation, bronchial edema, productive cough, bronchospasm, and go right back down here, air trapping, dyspnea, that means difficult breathing, frequent infections. Now, asthma, coughing, dyspnea, wheezing, chest tightness. Now, your textbook says active inflammation precedes bronchospasms. Some textbooks say bronchospasms cause inflammation. Either way, you're going to get both. And this inflammatory response, you're going to get an inflammatory exudate as well as bronchospasms. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. Symptoms: fever, night sweats, weight loss, racking cough, coughing up blood. There are antibiotics to treat them, but it requires a 12-month course of treatment. And if you get tuberculosis, you're going to go undergo mandatory home quarantine. Now, lung cancer is the leading cause of cancer death in North America. 90% are related to smoking. The 3 types we talk about here, most common types: squamous cell carcinoma, it comes from the bronchial epithelium. Adenocarcinoma comes from peripheral lung areas. Small cell carcinoma comes from lymphocyte-like cells. And any and all of these can metastasize to other tissues, and lungs to liver to brain, and eventually kill you. So don't smoke. Okay, that's all for now, and we'll go on to another subject.